Oh, no, it's all right. I've got it. It's coming now. Yeah. Okay, so you're being recorded as of now.
Okay, perfect. Yep, it's telling me on the bottom.
Yeah.
Oh, that's good.
And I'm muting myself, and away you go.
Okay. All right then, folks. Well, thanks for coming on, and Bonnie, bear with it. Then you know, I know what technology's like. To me as well. So we'll go through it. Now, what I want to do, so the webinar that I'm doing today is like the others have done. It's building on stuff that I sort of mentioned a bit when we had the one-day conference. But what I want to do is explore a bit further the issues around the actual evidence implementation, and particularly focusing in on the theories that you might find useful. So I've sort of tailored it so that there's a number of different theories that I'm going to look at and then explore some of the challenges, but then end up on the positives as to where they've actually been used. And then the next webinar, what I'll do is I'll build on that, but actually start to look at some of the approaches that, you know, the actual tools really that you can use. But I thought it would be best to actually talk about the theory side of things first, because that just gives you that bigger overview. So hopefully that'll fit in with everything, and it hopefully generate some questions. So I'm just going to go on to the next slide. This next slide is just really the learning outcomes that hopefully you'll be able to achieve as we go through today. Then when we did when I spoke at the conference, one of the things I flagged up was Jeremy Grimshaw's work that he's been doing in relation to implementation and the knowledge and the translation of evidence into practice. And he identified these 4 points that I think it's worth going over to, you know, looking at, we're just reminding you of really today. So you've got these issues of things like, despite all the work that's been done around with all the theories and everything else, and you know, we've been looking at this now for, you know, quite a few years, then we've got this issue of there's a failure to a big failure really to translate research findings into practice. So there's quite a time delay. Some of them get there, but there's just a time delay. Then you've got issues around the delays causing this suboptimal benefit to patients. So we know that there's, in terms of like drug trials, the effects of drug trials and things like that, there's significant delays in getting the best evidence utilised in practice for a whole range of different disease types. What that's then doing is clearly meaning that these patients, because they're not getting the best healthcare advances or benefiting from that, then we're exposing them in some cases to unnecessary risks of harm, and that then can cause the unnecessary costs. So it's a bit of a vicious cycle really, and it's one that we really need to think about how we can break. We've got, when we're talking about the implementation side of things, is an actual definition of implementation that I thought Carl May's developed, or he's put this forward, and it's been pretty much accepted across the board within the field, and it's just really useful so that we're all on the same wavelength really, that we know what it's about. So what we're talking about is something that isn't ad hoc. It's actually a deliberately initiated process, so it's something that's been thought about, it's been planned, you know, however long you've taken, to actually get something that's either new or been modified into practice, and then as a result of that, you get a change within the system. In this case, say within healthcare. So that's what we mean when we're talking about the implementation. We're not talking about an ad hoc system. Hopefully, it's a bit more structured than that. Accordingly, what we've got is theory that has come out from that. So like most aspects of knowledge, there's theories aligned to these particular practice changes, or underpinning this whole thing around implementation science. And implementation theory was described here by Susan Mickey, and I'll come back to her later. And what she's saying is there needs to be a behaviour change taking place. So whatever we do with the implementation world, there has to be some form of behaviour change, and hopefully it's a longer lasting one. So the aim of that implementation theory is to get a collection of tools, or develop the tools that then we can be used by both researchers and practitioners to really help to describe and then explain what it is needs to be implemented and what practice changes need to occur to get the desired outcome. So hopefully that's making sense so far, if everybody's still with me. There's sort of a number of different broad groups of theories, and there are so many. Brilliant, Ray's agreed, he's with you so far. So we've got a number of different groups of theories. Now I'm not going to go through all of these because we'll be here forever and a day and you'll be fast asleep. It's Friday afternoon. But what we've got, these three groups, you've got motivational theories, you've got action theories, and generally you've got organisational theories. I would say the most ones the older ones are probably the ones around action. So I don't know how many of you can remember years and years ago when you probably did something on psychology at school and you heard the work of Skinner and talked about Pavlov's dogs, where you've got these dogs that were trained to salivate on stimulus, and it just showed that you can, by operant conditioning, you can create a behaviour change that's really caused by a trigger. So they see the trigger and the behaviour change starts. Now, I would guess that within healthcare there's plenty of examples of barking and strange voice on the computer, yeah. So in healthcare, I think that there's a whole range of different things where we've been, as nurses or as health professionals, we've been operantly conditioned. So it's like, say with the, a crash call goes, somebody pulls the emergency button, you go into a particular, you hear the trigger, you know exactly what you need to do, and you go into that. So there's been a conditioning that's taken place. It's certainly one way of getting behaviour change occurring, but in the main, you don't actually want to, you don't necessarily want to trigger that. You don't want this almost automatic behaviour starting. You want to be able to ensure that there's a bit more learning and a bit more thought and tailoring maybe that's gone on board. So the motivational theories were probably the next group of where there's been an awful lot of work. And so you've got this thing that called the, where you've got the theory of planned behaviour. So that's by Abson. And he's done a lot of work around this, looking to see sort of what are the influences of behaviour. And so you've got influences, sort of the people's attitudes, you've got societal norms, and then you've got this behavioural intention. And where you've got those three things working together, generally you'll get an intention, an intention to do a behaviour or change something, to do an action, and then hopefully you're going to see a consequential behaviour change occurring. Most of the work doesn't actually go on to look at does that behaviour change occur. It's usually that intended behaviour, whether you say you're going to do something. The third one looks at a much broad. So we've looked very much at the individual's behaviour. The organisational group is very much at that bigger level. So it's that institutional level change. And I'd say the biggest, or probably the most well-known work around that is the diffusion of innovation, and that's by Everett Rogers. And he looked at the how, why, and at what rate that you could get things such as a new device or new technology. How quickly can you get it spreading across an organisation? So they're looking at different levels and at different issues. What we're going to do today is to take some of those sort of broad categories, but actually drill down to that next level and say, okay, what are the things that today are arising that I think that would be really useful when we're looking at the future, and given the fact that the whole modules looking at healthcare futures is what are the developments, where are things going, and how can you use things for the future. So these are the four that I'm going to focus in on today, because I just think that it will be that these are ones that I think have got the biggest resonance to healthcare and to what the type of changes that in the future you might need to be making. So we're going, hopefully you'll agree with me towards the end. And we'll start with the theoretical domains framework. Now it sounds really wordy, and it's actually makes some real sense. And so this is where Susan Mickey comes in. So she was part of a team. She's a psychologist and has been working on behaviour change for many years now. And she triggered off an expert consensus process and subsequent validation to try to identify what were the theories, what were the concepts that really were relevant when we're talking about health practitioners and getting clinical behaviour change occurring. And what came out of this expert consensus discussions were a set of 12 domains that really focused in on the key things that need to be addressed if we're going to get practitioner behaviour, clinical behaviour and general behaviour change occurring. And that was probably about 10, no not 10, about 7 years ago that this work sort of came to its sort of final, some of its major publications. More recently, like a couple of years ago, there was a revision or a revalidation of the process of this framework, and a further 2 domains were added, and I'll show you them in a minute. The useful thing with the theoretical domains framework is that it's quite adaptable and you can use it in a number of different ways, and it's a framework that I've used in my own research in different ways. So you can actually use it to help to develop interview questions, and so you can phrase interview questions to address the different domains. You can do the same thing with questionnaire items. And so you can begin to tease out where people's, in a more either qualitative or a quantitative format, where people are naturally tending to, almost in a, if you can do it, say, in a pre-post design. Usefully, it can also be used as a coding framework. So again, I've used it for coding semi-structured interviews and particularly focus groups. So you have a semi-structured interview guide or a focus group guide which is looking at the issue, say we looked at it with regard to introduction of the acceptability of new technology. What we then did was look at the transcript and identify and analyse the against the theoretical domains framework. It'll make more show you what the framework is. So these are the 14 domains of the revised framework, and you can see they cover a whole range of so very much personal behaviours, but looking at the contextual issues as well. So things like knowledge and skills you'd expect to see, but also what are the issues around professional role and identity. So when we were looking at the work around this new technology, it was really, it was beginning to come up where there was a bit of confusion as to people weren't sure where this really fitted in with their professional roles at the time. There were also things looking at beliefs about capability, so looking at confidence, how capable were people to manage the technology. We could have done the same with, we're starting, how to use webinars and chat rooms. You could do a similar thing today. Optimism is an interesting one to look at because you can then say, okay, well, how realistic is it for people? How do people see things for the future? And so, is it something like, particularly looking at pre and post, is optimism something that comes through at the pre-stage? You would hopefully begin to see more of it at the post, and so it goes on through. looking at things like looking at the environmental context and resources. So again, it's broadening it out a bit, so not just what the individual thinks, but what are the bigger ramifications of this, and is it something that people are aware of. So all of these, Mickey's group felt that these were things that need to be there to get optimum implementation occurring. I'll just get my piece of paper there. So the concept, so we've got a number of, so within each of these domains, there's a number of different concepts. Now, I'm just going to see whether this will work. I don't know how good it's going to be. I'm just going to see if I can click to get the, no, it's not going to work. Okay. If you click on here, I'm not going to do it. It takes you to a paper in implementation science where it actually shows the whole list of concepts and the design. I'm going to see if I can copy and paste the thing into it. So just bear with me. I'm just going to I'm just going to expand the internet box a minute and just see if I can get it coming up, because I think it'd be useful for you to see. So I'm just going to, oh, it might work. So what you should see now on the left-hand side of your screen is just an example of the different domains, so like the knowledge and skills and social and professional identity, and the constructs, or the that sort of from the broader topic, you've got a number of different sub-themes or subtopics that go into that. So I'm just going to flick back at you. Oh, you need to pull it across more. Okay, is that, hang on. Is that better? My mouse is moving. Is that better? I'm just making sure, seeing whether that works for you a bit better. If not, when you get what I've done is I've put the presentation up on as the resources on the module site. So if you go into this, because I think it's not coming up because I haven't got it on a slideshow. It worked fine when I did it as a slideshow. So if you just click on it, then you should be able to go into the box. Oh, a bit more. Hang on. Is that any better? Yeah. Okay. So, but as I say, all of these, I've got a whole range of hyperlinks within the PowerPoint that you can go into, and if you just click on it, because I've put the PDF version up, and if you click, the hyperlinks are built in, so you should be able to go in and you'll be able to see the bits, in more detail. So just take your time on that. I'm not going to sort of go over it too much today because I think A, you'll get bored, but B, you can listen to it at your own leisure then, if that's okay. So what I'm going to do now is just going to slide you back over again so I can see the there we are. Now, what this also did was it was informed by the development of an earlier model, and I'll just come to that one now. But there's a really nice PowerPoint presentation by Susan Mickey on the development of the theoretical domains framework, and it shows some of the research that they've used it by, how they've used it. So again, if you go to the shared documents page of the module website thing, the thing on the on Tulip, then you'll be able to access it. Oops, it's not going to. It's asking it's not going to do it now. Hang on, there we are. So this is your COM-B model. This is the model that looked at behaviour change that Susan developed first, that was then used to inform the, what's the name? Hang on, I'll just type it. I've typed it up for you, so hopefully you've got that. So yes, as I say, she's a psychologist. I think she's in, she could be Aberdeen or York or somewhere like that. I'll try and find out for you. She's one of the editors on implementation science, and she's a really that I work with on the journal, and she's really good. The stuff she comes up with is really, really good. So with this COM-B model, oh yeah, you're probably right, Ray. I think yes, she's at UCL now. So yeah, you're right. So COM-B is worthwhile just having a look at because it does make some sense, but because it helps you just to understand how people behave and how the issues around capability, people's the opportunity then interplay with motivation, and how each of those then can interact to cause, to create behaviour. So that's in a very, very quick fashion is the theoretical domains framework. It is very psychologically based, but it is very easy to use. There's been a lot of information published around this, and I've got another link further on down the line that will take you to a series of articles in implementation sites that have been published. And again, this provides some really useful guides as to how to use this theory. But I've used it on a number of occasions and I really like it. Oh, stupid. That's right, this thing's not working properly now. So the next model that we've got is the Paris model. And it's not a typo, it is called Paris. And it's the promoting action on research implementation in health services. This one was, unlike the psychology development, it was developed by nurse academics and researchers at the Royal College of Nursing in London when it had the institute. And it was led by Alison Kitson, sort of a team before. There was Alison Kitson, Joe Rycroft Malone, Brendan McCormack and Jill Harvey. They tried to develop a model it was in the 1990s actually, where they were beginning to say, okay, well, how do we get this evidence that's related to nursing into practice? And so from a very much nursing point of view at this point, they identified that there were these three main areas of activity that were needed to get implementation occurring. And these were then assessed, and they were assessed as being on a continuum between weak and strong. So you've got the issues around evidence, you've got the issues around context, and we need to look at facilitation as well. And then, like the theoretical domains framework, within each of these there's a number of different concepts, and so it helps to just expand it, just so you can have a look to see what falls within that and just how they work together. This next slide shows you there's sort of three areas, three pictures, which show you the formula that Alison came up with to look at how do you get successful implementation. So they said successful implementation was a combination of evidence facilitation and context, and when they're all working together, you get that's the outcome. And so the cube at the bottom shows that where you've got where everything's sort of tending towards high or strong, you get implementation occurring more quickly and more effectively. The little box on the side that you can't really see is to do with facilitation, so ignore that bit. Just bear with me. That's all right. My husband's left the door open. That's beside the point. So within each of those domains, so the evidence, the context, and the facilitation, you've got these sub-elements, and these are within the evidence sub-element, you've got things like research evidence, clinical experience, patient experiences and preferences, and also local information. And so something that would be assessed as being on the weak side, particularly say in relation to research evidence, is if the level of the evidence available for that intervention or application is at anecdotal level or very descriptive level. So it's based pretty much on the traditional levels of evidence. When you're looking, say, at something like patient preferences, though, you're looking a weak one, something that would be assessed as being weak, would be something where you've got patient's not really being involved in in any form of partnership at all, and so really, although it might be a patient-related intervention, they've not got any say in that at the moment, or the evidence doesn't give any indication about how patients can be involved. The strong would be where the evidence there's a clear body of evidence that says this is the partnership, this is how it works. So that's the evidence. With the context, a number of different sub-elements again. So you've got culture, leadership and evaluation. And so an example would be of the organisational culture, or the culture just within the ward. If it was weak, it'd be something like very task-driven, morale's pretty low. Generally it's not a good environment to try to get change occurring. Something that would be seen as strong, where you've got in terms of culture, you've got something that really demonstrates it's a learning organisation. So you've got a really active community of practice going on there, or something that's particularly patient-centred. With evaluation, you've got things where you've got an absence of audit and feedback, or you've got things where routine audit and feedback and that reflection, that looking at that inquiry into practice goes on. So it's a much nicer environment to try to get practice change occur. Facilitation is probably the hardest one to try to measure, because it's far more subjective, because what you're really looking at is the characteristics of the facilitator or facilitators. You've got the role that the facilitators have, but also you've got the style. And so it's very much looking to see, in terms of getting that practice change occurring, how well prepared are people? Is there the infrastructure there? Is there even a facilitator there who you can use, because they're vitally important to try to keep that practice change occurring? So those are some issues around the sub-elements. The useful thing that we've got now with Paris is that there's been almost as a re-look at it. So because it was quite a few years since it was first developed, Cheryl Stettler and Laura Damschroeder, who were two Americans, and they've been involved in practice change for quite a long time. They looked at it and tried to explore how to make some of the weaknesses of this particular theory, and how to make it a bit more user-friendly, and where there was a lack of clarity. And what I've done is I've put their paper that they put together. Again, I've put that up on the website, on the Tulip, and that's in the shared documents. And I think it's under step. And so with the Paris framework, you've got this. We know that as a result of it, successful implementation is most likely to occur when we've got the evidence is sound, and it is in keeping with the professionals and the patient beliefs, where you've got a culture that's really receptive to change, and that there's mechanisms in place that's going to facilitate that implementation. And the reference there, the hyperlink there, is the one to Cheryl Stettler's work. Okay, so we've had very much a behavioural one. We've had more of a nursing focus, but more of a sort of bit more of a local organisational change model. The third one I want to briefly have a look at is knowledge to action framework. It's maybe one that you're probably a bit more familiar with. I don't know. It's the early to mid 2000s when it was really started to come out, and it was developed in Canada by Ian Graham and his colleagues at the Canadian Institutes for Health Research. Ian was the vice president of the CIHR, but has got a sociology background, and he's a really interesting bloke to talk to, and was really grounded. He's got his head very much fixed and is very aware of the changes, that the issues around trying to get practice change occurring. And it was a result of that that they wanted to come up with a framework that was really useful to clinicians and clinicians, but also for researchers to get activity occurring. And this one focuses in on two main areas of activity. You've got knowledge tailoring, but then you've got the evidence implementation. So they're two interlinked processes. The thing to note as well is the dynamic process, so it's not a linear model at all. There's a PowerPoint that I've put up again on the site by Jacqueline Tetreault that explains this further. And basically the KTA framework rose from it was a concept analysis of 31 planned action theories to try to provide guidance to those wanting to really know more about how to do knowledge translation. It follows a systems perspective, so we've had a psychological perspective, an organisational perspective, but really sort of now a broader systems perspective. And it falls within the paradigm of social construction, which basically requires or emphasises the fact that you need social interaction and you need adaptation to take place, and that adaptation is vital because it needs to take into account the local context and culture. So the knowledge to action framework provides this cyclic, you've got in the middle, you've got this inverted triangle, and that's to do with knowledge, that's where the knowledge creation and the knowledge, hang on, I've lost it now, whatever it is, the bit going down, I can't read it, where that helps to generate the technologies and the toolkit. So you've got the inquiry, you've got the synthesis, and a product at the end of it, so almost like a toolkit at the end of it. Round the outside, you've got the action cycle. So you've got the very much the application of that knowledge taking place, and they're not. It doesn't sort of go round in a linear way. So the circle in the middle can whiz round, or can be tilted round. So at any time within that cycle, you can have this knowledge. It can generate knowledge creation and the integration. And so you might want to say, okay, we're going through this process of adaptation. Well, the adaptation might reveal that something else needs to be done, so you go back into the knowledge creation phase. So it is very much of a dynamic process. Yeah, did say social constructivism. So I'm just looking to see my, yes, it's social constructivism with looking at social interaction and adaptation. So that's the framework, and it's worth having, as I say, it's worth having a look at Jacqueline's PowerPoint. Oh, it's not clicking down. So the KT, that's done in a number of, so you've got that inverted triangle where you've got the knowledge creation bit, and so often you've got things like looking at the primary, looking at what the knowledge is from the primary studies. Then the synthesis of those primary studies. So this is where the systematic reviews or meta-analyses or meta-syntheses come in to try to pull that information together. Once you've got that information pulled together, you can start to get the generation of things like clinical practice guidelines, looking at decision aids, or you might want look at care pathways, but they're all informed by the evidence. So at the bottom of that triangle, you get spat out this, you've got this pot of, you've got these tools that you can use. You've then got 7 phases of the action cycle to go that, which is the outside cycle, the outer circle, and you've got things like the, well, what's the gap? Locally, what's that knowledge to action gap? What tailoring needs to take place to bear in mind that the local context, because we're not, the information may have been generated in Australia, and we may be looking at, say, Devon or Cornwall, and might be totally different. The context might be slightly different. care. Then you need to look at, okay, what are the barriers that are there? What are the facilitators to that knowledge use? So what's going to encourage the uptake? What's going to be there to prevent it occurring? And then looking at the actual interventions that you're likely to use. And we'll come back to this at the next seminar, because that's what I'm going to focus in on there. You then need to monitor the knowledge use, you need to evaluate the outcomes, and then look to see, are we getting this sustainable knowledge use occurring? And so all the time the inner circles moving around to see, is there more work that needs to be done? So it's a really nice, it can provide a really nice program of work, but it's good to, you know, it works really, really well. So that's knowledge to action in a very brief, concise, you know, format. And I'm whizzing through them, so I'm hoping that, you know, you're sticking with me. This next one, the normalization process theory, I'm not going to focus in too much on that. So it's normalization process theory. That's what it stands for. What the MPT stands for. This one is probably less evident in the local literature, so the more smaller scale implementation changes that are taking place, and it's probably more appropriate to the, it's probably been more used in the bigger changes, the organisational change. This one focuses in on helping people to understand what are the processes that go on, or that are around, that you need to be aware of, that can lead to changes or innovations being embedded into becoming everyday work. It's very much of a sociological framework again, and there's a whole toolkit, there's a whole website with so much information around this that, you know, again, you can spend the whole day just going over the normalization process theory. I would suggest you go to have a look at the link, because the link gives you the history, but it also gives you the toolkit and helps to explain how the toolkit works to make it so that it's useful to you. And again, it's probably one of the things that, you know, when we've got the you know, then over the next few days, you know, we've got some time available, keep pinging emails back to me, or, you know, we can get onto the chat room or whatever, to because there may be some things in there that you think, oh, you know, that looks, it's good, but how does it work? I'm not an expert on normalization process theory. I have seen it being used, and I think it's one that is going to be used more often, but it's probably less, it takes a bit more thinking about, because of the way it's being developed, and that is that higher level activity. So what I've done at the moment is look at the different 4 different theories that you could you might want to use. Naturally, then there's this issue. Okay, well, how do we, you know, why do we choose one against the other? And the trouble is, there's no hard and fast rules, and it's often a pragmatic choice. What I would say is, if you focus on really look at what it is you want to change, and then what's the, you know, is it small scale, is it larger scale, which one of these might have the best fit. When I've used the theoretical domains framework, it's been really early on in some, you know, real innovative, novel approaches, and how do we get how well will this be accepted within the clinical setting? And you can use it, you can build on that, you know. So I've used it in a number of different ways, but it's really just slowly building on just seeing where, you know, as things get introduced, how do people's behaviour, you know, how does people's behaviour change? Cheryl Steckler came up with a bit of a plan for using theory, and again, it's one of these. It's a useful tool, and this she's done some work with Laura. This is again with Laura Damschroeder, and looked at things like, okay, well, where do we, we can have our we have our own particular likings for theory. So I like the Paris framework, and I like for looking at clinical change and getting clinical change occurring. I like the theoretical domain framework for getting for this earlier stage. Knowledge to action framework, as I get to know it more and more and use it more and more, it's actually it provides more of a program approach to change, rather than more so than perhaps Paris does. So you can look at the theory behind it and then sort of think, okay, well, what are the strategies that we need to do? What are the interventions that we need to look at? What are the tools? And then go through that. So it's very similar really to the knowledge to action framework, the outer circle. She, in some ways, it looks like Cheryl sort of used an element of that to, was being in, to what, I don't know which came first, chicken or the egg, but there's some clear similarities. Now, I'm mindful of time, so what I'm going to do is whiz on now and just think about, okay, what are the challenges that have been faced? Because there's challenges with every theory. And so what I've done is I've just highlighted one set of challenges, and these were things that came out from the Paris framework, because this is one I think that's probably got the biggest, the really closest, alignment with what you're doing. And Bonnie, yeah, it's good to see that, hopefully it will be useful to you. And, look, I'm here to provide some assistance with that if you need it. In relation to Paris, one of the things with the original theory, that some of the criticisms that came up was too broad. If you think about the got evidence context, and you look at the sub-concepts within, what do they actually mean? And so Cheryl said, look, we've got a lack of conceptual clarity. We haven't really got transparency as to how things are being interpreted. There's variations there. It's a bit too, there's a bit too much scope for variation. They also felt that there was a lack of elements that were perceived to be crucial for implementation. And finally, which is probably a biggie, is the lack of well-developed instruments. So what are the tools, what's that? We needed some toolkits. So what Cheryl went on to do is to address some of those challenges, and actually there's a guide now. So again, that implementation science document, that actually provides, if you go into the implementation science website, there's a whole pile of additional files, and they've got the guides that are really helpful to get you to use Paris in action. And maybe that's something that I can talk about. We can go through at the final seminar, the final conference, if it's something that will be useful. So just keep me in the loop on that. I'm talking very much at clinicians and health professionals. Policymakers, I did talk about, they don't get lost in the system, but it's not an area that I've done so much work in. But I mentioned about support at the one-day conference, and again, it's one of these things where there are a lot of tools, and it may be of use to some of you, it may be of use in the future. So the support collaboration have developed tools that address these key areas. So looking at how do you get evidence-informed policy making. What are the research? What do we need to make sure that we've got that evidence in place? So clarifying the problems, looking at the options, and planning implementation. Where's the evidence coming from? So how does this inform systematic reviews in relation to policy? And then how do we shift from just having the research evidence to actually getting it into and informing policy? So again, there's a couple of links there. Have a look at them if it's relevant to you. If not, it might be something that's there in the future. it's entirely up to you. So these are just some pictures. This is just some at the table, that a picture of the diagram that the support organisation put together. Now, what I thought I'd do, oops, I've gone too far, is to end up on some positive notes, again to give you some useful information on how they've been applied, how these theories have been applied. Starting off with the theoretical domain framework, this paper implementation science, so they did a special volume, and I think there's about 6 or 8 papers, a collection of papers, where they've used the theoretical domains framework to explore and implement evidence and get changes occurring. So one of the papers, for example, looks at the factors needed to influence the 4 key evidence-based recommendations for managing mild traumatic brain injury. And again, Bonnie, it might be useful. This sort of thing might be useful for you. This was a qualitative study that really looked at using focus groups, and then using the theoretical domains framework in the way probably that I used it in clinical practice to map against the findings of the focus groups to see where the gaps are and because then you can target interventions, and this is where a real strength of this lies, because you can really get by mapping it, you can see where the things are that get talked about a lot, but also what doesn't get talked about, and that's generally the areas that you've got to go in and do some more work. So it's a really useful one to look at. Now with Paris, it's been progressively more used. 2 studies that are well worth having a look at, or just a webpage. Jo Rycroft-Malone is now at Bangor University, and she's got a whole implementation research group going there. And at the moment they're using Paris to explore improvement opportunities with North Wales Police to see, particularly around antisocial behaviour, try and find effective solutions to antisocial behaviour. And that's really revolutionary, because I don't know of any of the police forces really that are actually looking at an evidence-based approach to things. So this is one where I think we've got some real potential, and that transferability, and it's going to really test the scope of this framework, because it's been primarily looking at healthcare, and can it be, and clearly they're looking to see, can it be translated elsewhere outside. The other one that's ongoing is the fire study, and this was funded by the frameworks, European Union Framework 7 funding. And this is looking at implementation in looking at continence activities. And Ray, if you're still online, I think this was the one that I sent through. Yes, it was, that I sent through to you today. So the fire study is really focusing in on the facilitation side of things and what's needed to get facilitation occurring. So again, have a look at it, and it's just useful to get a feel from the PowerPoint. This was presented at the RCN conference last year, so it's an ongoing project. It started, I think, in 2011 or 2012, so it's data's coming out, and it's still got a bit to go. Now the knowledge to action framework, it's been, there's a lot of projects. It's been well used in Canada, and there's been lots and lots of submissions under from the Canadian Institutes for Health Research looking at this particular framework. One that's been taken up fairly recently in 2010, the World Health Organization they're sponsoring the project, and they're using KTA to look at sexual and reproductive health in Africa and South Asia. And so it's showing that it's not just a local thing, but it can be much, you can apply it on a much bigger scale. One of my PhD, or a couple of my PhD students are using KTA at the moment, and it's really being useful to guide the production of evidence using a systematic review, and then how do you get that in, how do you start to look and see to get it implemented into practice. So one of the girls is looking at severe traumatic brain injury and looking at developing evidence care, an evidence bundle to use in southern Thailand in the emergency department, because they've just got there's just very, very little evidence that's applicable to that particular setting. So they're using KTA to see what tailoring's needed to get Western bundles, Western evidence used in a very, very different clinical setting. And if anybody's interested, I've got some amazing pictures of the not very high-tech emergency department. The normalisation process theory. Now this is interesting, because this is a project that I first came across in about 2010. When I was this came up as a European Framework 7 application, and I was an expert evaluator on the call. So I was one of the experts reviewing this and and agreed that it needed funding. So it's good to see how it's developing, and it was probably my first exposure really to the normalisation process theory. This one's looking at the issues around medical and psychosocial primary care for migrants. So really highly pertinent, and really going to be provide some extremely useful information. And they're looking at it across in a number of settings, both in the developed and the the new European countries, as well as the existing European, the older European countries. So looking at that transferability really, really nicely. So I'm going to finish up just to flag you with some of the developments that are occurring. So we've got the definition of implementation research there by Eccles and Mittman. So that's pretty much setting the scene. But what we're seeing now is it being shifted into much broader. The Eccles and Mittman definition was very much around healthcare. What we're beginning to see now is that there needs to be, these approaches need to be applied to a much broader setting, and so it may be something that we start to look at with the sustainability themes, with looking at the issues around social care and age, with the older person. Be interesting to see even with Heather's work where it fits in, and also with the improvements, looking at the development technological improvements that are changing. So there's a lot of movement in that particular sphere. And the other one that I wanted to flag up is the issue that I mentioned at the one-day workshop, is around knowledge mobilisation, and the work that's being done at St Andrews and elsewhere. Because although we have the knowledge translation, the recognition now is it needs to be broader. It needs to look at not just the pushing of information, but the pulling, and how we get that knowledge exchange taking place. And we've just had a success in the Southwest, and hopefully that'll get made public very, very soon, but you can have it hot off the press. And one of the Penn Clark researchers, Ian Lang, he's just been awarded a knowledge mobilisation fellowship, and that's for, I think it's 3 years. And he's looking at, going to be looking at the issues around the needs of carers and in terms of dementia, and how do we bring the evidence that's out there, how do we mobilise it and get it so that we minimise some of the inconsistencies in care. So that's me done. Hopefully it's given you a lot of things to think about and food for thought, and have a look at those the resources that I put up on the website, and just see really how how things. Hopefully they'll make sense. If we don't, we need to get an Erasmus PhD nurses to talk. Yeah, we do actually. It will be really interesting to see what how we can start to broaden things. I would love to see a start. I think we need. There's so much opportunity in relation to getting implementation from. Oh yeah, are they the Spanish nurses? I think that I saw them in the cafe the other day. So yeah, it would be interesting to see how we can start to get some collaborative work going. Yeah, we need to. Right, one of them's looking at needs of care. Excellent. How long are they over here for, Ray? Busy typing. Because I'm not. Is it because generally they're here for a period of time? Is it? Oh, okay, 6 weeks. Oh, we'd have to see if we can get them together. They might actually be able to talk at the one-day conference, Ray. You know, the final one of the module. It might be a useful source of information. But certainly we could get. We need to get some. We need to start to get some links. You know, get this research moving forward. Yes, that's a good idea. Yeah, we can ask them to do posters. Yeah, that'll be excellent. I just think there's some real opportunities, and you know, see how it goes. I'm looking forward to what I'd like to do. If you can send me some ideas of where you might be able to, you know, sort of over the next few days, email me them or whatever, and see where we can get some ideas going and using the beginning to using some of this information. So Bonnie, what I was talking about was if we can get some information coming through about the where we can use this the theories. Bonnie, Ray's asking what your new role is. Do you want to say, because I get it keeps changing, or it probably doesn't keep changing, but it's a very exciting role. So yeah, so Bonnie's got a role of advanced nurse practitioner in the emergency department up at Derriford, and I think there's some really good improvements. So yeah, lots and lots of things to do. Now, Ray, should we sort of curtail the recording or whatever now, and then, as I say, we can carry on conversations either via the chat room over the next few days, or we can. Oh, you're coming back on?
Oh no, it's all right. I've got it. It's coming now. As yet. Okay, so you're being recorded as of now. Okay,
perfect. Yep, it's telling me on the bottom.
Yeah.
Oh, that's good.
And I'm muting myself, and away you go.
Okay. All right then, folks. Well, thanks for coming on, and Bonnie, bear with it. Then I know what technology's like. To me as well. So we'll go through it. Now, what I want to do, so the webinar that I'm doing today is like the others have done. It's building on stuff that I sort of mentioned a bit when we had the one-day conference, but what I want to do is explore a bit further the issues around the actual evidence implementation, and particularly focusing in on the theories that you might find useful. So I've sort of tailored it so that there's a number of different theories that I'm going to look at, and then explore some of the challenges, but then end up on the positives as to where they've actually been used. And then the next webinar, what I'll do is I'll build on that, but actually start to look at some of the approaches that, the actual tools really that you can use. But I thought it would be best to actually talk about the theory side of things first, because that just gives you that bigger overview. So hopefully that'll fit in with everything, and it hopes changes or underpinning this whole thing around implementation science. And implementation theory was described here by Susan Mickey, and I'll come back to her later. And what she's saying is there needs to be a behaviour change taking place. So whatever we do with the implementation world, there has to be some form of behaviour change, and hopefully it's a longer lasting one. So the aim of that implementation theory is to get a collection of tools, or develop the tools that then we can be used by both researchers and practitioners to really help to describe and then explain what it is needs to be implemented and what practice changes need to occur to get the desired outcome. So hopefully that's making sense so far, if everybody's still with me. There's a number of different broad groups of theories, and there are so many. Brilliant, Ray's agreed. He's with you so far. So we've got a number of different groups of theories. Now I'm not going to go through all of these because we'll be here forever and a day and you'll be fast asleep. It's Friday afternoon. But what we've got, these three groups, you've got motivational theories, you've got action theories, and generally you've got organisational theories. I would say the most ones the older ones are probably the ones around action. So I don't know how many of you can remember years and years ago when you probably did something on psychology at school and you heard the work of Skinner and talked about Pavlov's dogs, where you've got these dogs that were trained to salivate on stimulus, and it just showed that you can, by operant conditioning, you can create a behaviour change that's really caused by a trigger. So they see the trigger and the behaviour change starts. Now, I would guess that within healthcare there's plenty of examples of barking and strange voice on the computer, yeah. So in healthcare, I think that there's a whole range of different things where we've been, as nurses or as health professionals, we've been operantly conditioned. So it's like, say with the, a crash call goes, somebody pulls the emergency button, you go into a particular, you hear the trigger, you know exactly what you need to do, and you go into that. So there's been a conditioning that's taken place. It's certainly one way of getting behaviour change occurring, but in the main, you don't actually want to, you don't necessarily want to trigger that. You don't want this almost automatic behaviour starting. You want to be able to ensure that there's a bit more learning and a bit more thought and tailoring maybe that's gone on board. So that these patients, because they're not getting the best health, the best healthcare advances or benefiting from that, then we're exposing them in some cases to unnecessary risks of harm, and that then can cause the unnecessary costs. So it's a bit of a vicious cycle really, and it's one that we really need to think about how we can break. We've got, when we're talking about the implementation side of things, is an actual definition of implementation that I thought Carl May's developed, or he's put this forward, and it's been pretty much accepted across the board within the field, and it's just really useful so that we're all on the same wavelength really, that we know what it's about. So what we're talking about is something that isn't ad hoc. It's actually a deliberately initiated process, so it's something that's been thought about, it's been planned, however long you've taken, to actually get something that's either new or been modified into practice, and then as a result of that, you get a change within the system. In this case, say within healthcare. So that's what we mean when we're talking about the implementation. We're not talking about an ad hoc system. Hopefully, it's a bit more structured than that. Accordingly, what we've got is theory that has come out from that. So like most aspects of knowledge, there's theories aligned to these particular practices. Hopefully generate some questions. So I'm just going to go on to the next slide. This next slide is just really the learning outcomes that hopefully you'll be able to achieve as we go through today. Then when we did when I spoke at the conference, one of the things I flagged up was Jeremy Grimshaw's work that he's been doing in relation to implementation and the knowledge and the translation of evidence into practice. And he identified these 4 points that I think it's worth going over to, looking at, just reminding you of really today. So you've got these issues of things like despite all the work that's been done around with all the theories and everything else, and we've been looking at this now for quite a few years, then we've got this issue of there's a failure to a big failure really to translate research findings into practice. So there's quite a time delay. Some of them get there, but there's just a time delay. Then you've got issues around the delays causing this suboptimal benefit to patients. So we know that there's, in terms of like drug trials, the effects of drug trials and things like that, there's significant delays in getting the best evidence utilised in practice for a whole range of different disease types. What that's then doing is clearly meaning